Hey, good morning. I am Zatisha, and this is Jada Thigpen, and we're going to be talking to you guys about coccydynia. Students will learn about what causes coccydynia, its signs and symptoms, likely functional limitations, and how it is tested and measured. Students will also learn the differential diagnosis and its rehabilitation process with a listing some outcomes and giving a brief overview at the end. Okay, so what is it? Coccydynia occurs when there is pain in or around the coccyx region due to a displaced tailbone. The coccyx may become stuck into flexion while also deviating or shifting, causing pain and discomfort. Dominant muscles that can be affected in this area is the levator ani group, which consists of the pubococcygeus, the iliococcygeus, and the puborectalis. The several ligaments that may be injured in this region is the anterior ligament of the coccyx, the superficial posterior, deep posterior, and lateral portion of the sacrococcygeal ligament, and the intercorneal ligament. And it is women are 4 times more likely to have coccydynia symptoms, and people with increased body mass are 3 times more likely. Okay, so the different classifications, according to Physiopedia, these classifications describes the different shapes of the coccyx as observed in various people, which can impact how prone a person might be to coccydynia. So for type 1, the coccyx is slightly curved forward with its apex position downward. Type 2, the forward curvature of the coccyx is more exaggerated with apex position in a straightforward direction. Type 3, sharp angulation of the coccyx forward, and then type 4 is a subluxation of the coccyx. Okay, so the pathomechanics of this condition include these listed. The direct trauma to the coccyx, such as falls or impact injury, is a common cause. This can lead to bruising, fractures, ligament damage, causing instability or misalignment. During pregnancy, hormonal changes causes ligament relaxation and pelvic floor stretching, which can cause alignment and mobility issues. With obesity, the coccyx is more vulnerable to increased intrapelvic pressure while sitting. With rapid weight loss, the cushioning of the coccyx may be lost and increased risk for anterior subluxation or displacement forward. As we age, degenerative changes in the sacrococcygeal joint may occur, leading to pain from joint stiffness, inflammation, and reduced cushioning. And coccydynia is more common in women due to the fact of their anatomy differences, including a wider pelvis and a greater mobility of the coccyx, which increase susceptibility to stress and injury. And then, because the muscles attached to the coccyx may cause tension or misalignment. And after childbirth, changes in the pelvic floor and coccyx positioning combined with ligament laxity can contribute to coccyx pain. So, okay, some signs and symptoms: hypermobility, hypomobility, tenderness, guarding seated posture, aching in the lower sacrum, coccyx, and nearby soft tissue muscles, localized pain, pulling and cutting sensation at the sacrococcygeal joint, challenges performing bowel movement, soreness, and low back pain.
All right, so when we get into functional limitations, based off the anatomy that Z just showed, you would expect these people to have difficulty sitting for prolonged periods of time, also difficulty rising from a seated position. They also have troubles bending over and doing any activities that lead to increased strain on the levator ani muscle. So bowel movements could pose a problem for these individuals. All right, so test and measures. The diagnosis is based on the clinical presentation. We can use CT scans, X-rays, MRIs, palpation. We also can use the sit-to-stand test, as you are familiar with, and the straight leg raise test. It was also mentioned that dynamic radiographs are taken in both sitting and standing positions, and this can provide measurements of the coccygeal displacement. So, for conditions that also mimic this condition, you can have a coccyx fracture, and this will be able to be seen through an X-ray. Lumbar spondylosis or disc herniation. This condition will also be able to be seen through like MRIs and things like that, and the pain that this person or that patient would experience would be a little bit different compared to our condition. You also have Levator-Andy syndrome and piriformis syndrome, and all of these conditions, it will be important to pay attention to what the patient is saying in the examination, because the pain that they're experiencing, the location of the pain will determine where or guide our clinical intervention. So when we get into the rehab process, for the maximum protection phase, the goals here are to reduce pain and inflammation, minimize toxic pressure and discomfort, and also prevent muscle overactivity and guarding in the pelvic floor. So interventions will include pain management like ice or TENS, postural education, some gentle soft tissue and joint mobilizations, and gentle stretching. The moderate protection phase, the goals here are to continue reducing pain and inflammation, restore gentle muscle activity and mobility, improve posture and pelvic alignment. So the interventions would be pelvic tilts and core stabilization exercises, manual therapy, pelvic floor relaxation exercises, some neuromuscular re-ed, and also patient education. And then in the last phase, the minimum protection phase, goals here are to fully restore functional strength, flexibility, and endurance, minimize recurrence risk, and promote long-term independence, and address any residual function, limitations, or pain. So here we would incorporate strengthening exercises, postural training, functional movement, and also continue with the patient education. Physical therapy, when dealing with this population, is very important, or we read that it was very important to focus on the pelvis and pelvic muscles and muscles surrounding the sacrum, just to try to increase the stability that patient has. So for the outcome, Coccydynia appears to be best managed with conservative measures like massage, injections, and ganglion impact blocks. For patients with Coccydynia, the surgery, coccygenectomy, which is the removal of the tailbone, is an effective treatment option, but the patients have to meet a specific criteria to have this surgery. Study shows that patients who have the right indications and undergo this surgery have good or excellent outcomes, even though there might be a psychological component to the diagnosis. And even with patients who have chronic pain, this can have negative impacts on their quality of life if they do not meet the criteria to receive the surgery. So for an overview, Coccydynia is pain within the tailbone region. It can be caused by several factors such as trauma, pregnancy, obesity, age, gender, pelvic floor dysfunction, or Levator-Andy postpartum. Palpation, muscle assessment, and functional tests are used to localize the pain and determine the involvement of muscles, ligaments, or soft tissue. Conditions that present similar to Coccydynia include coccyx fracture, lumbar spondylosis or disc herniation, Levator-Andy syndrome, piriformis syndrome, etc. The rehab process focuses on pain management, muscle activity restoration, and functional strength improvement. And Coccydynia is typically treated conservatively, but the surgery may be effective for eligible patients with good outcomes despite potential psychological factors. These are our references.